Hello and welcome back to the PMHNP Podcast. This is Dr. John Rossi with Clarity Education Systems and www.pmhnptesting.com. So this is a different podcast today. We've had multiple requests from students and nurse practitioners also that wanted an audio version of our weekly live sessions on Wednesday nights where we go over 5 practice questions and then also have time for students and nurse practitioners to ask questions about their studies or practice in general, so whatever they would like to discuss. So this is basically a version of that. There's also a video of these practice questions, not me talking, it's just some music, or you can mute the music if that's not something you want to listen to, and then you can read the questions, get the answer right away, and that is in video format on YouTube and also on the Facebook channel. You can also see that video posted on the main page of the student portal for any students active in our PMHNP review courses. All right, so basically what we're going to do is we're going to practice 5 questions. I'll read the question, give you a pause. You can stop the podcast for a second if you want to just think about it, and then press play, and we'll go right into the answer and rationales for that question. So first one we're going to do is about an ethical response. So question number 1 reads, a PMHNP is treating a 30-year-old undocumented immigrant with a confirmed diagnosis of post-traumatic stress disorder, or PTSD, scoring 32 on the Clinician-Administered PTSD Scale, or what's known as the CAPS-5. Who expresses significant fear of seeking mental health services due to concerns about potential deportation. The patient reports nightmares and hypervigilance following a traumatic event in their home country and is reluctant to continue treatment despite severe symptoms. As a PMHNP, you must address this ethical dilemma, balancing the patient's safety, confidentiality, and cultural sensitivity. What is the PMHNP's most ethical response? Option A, report the patient's status to immigration authorities for proper intervention. B, reassure the patient that mental health treatment is not contingent upon immigration status. C, document the patient's concerns and avoid further discussion of legal issues. Or option D, advise the patient to seek legal counsel before continuing psychiatric treatment. All right, and the answer is B. So we want to reassure the patient that mental health treatment is not contingent upon immigration status, and then we encourage access to care that best identifies the most ethical response for the patient and the nurse practitioner. So the PMHNP's primary obligation here is outlined in the American Nurses Association Code of Ethics and reinforced by HIPAA, is going to be to provide care without discrimination and maintain confidentiality, regardless of immigration status. So this 30-year-old undocumented immigrant's severe PTSD, as noticed by a CAPS-5 score of 32, is marked by nightmares and hypervigilance. So this indicates a critical need for treatment, and their fear of deportation is going to reflect a valid concern about privacy breaches. So reassuring the patient that mental health services are not reported to immigration authorities, emphasizing confidentiality except in those cases of imminent harm, and then encouraging continued care, for example, trauma-focused CBT or sertraline. This is going to uphold the beneficence and justice, fostering trust. The PMHNP should also explore community resources like free clinics if needed. And this is going to align with the PMHNP's role in culturally competent and ethical psychiatric care. So why were the other options incorrect? For option A, reporting the patient's status to immigration authorities violates confidentiality and the ethical duty to protect the patient's privacy under HIPAA. So unless there is some type of imminent threat like violence, which is absent in this case, this would deter care and harm the patient, and it's making it the least ethical response. Option C, documenting the patient's concerns and avoiding further discussion. This really neglects the patient's need for reassurance and support, and this is going to potentially lead to treatment dropout. So while documentation is important, it is insufficient without addressing her fears, rendering this option totally incomplete. And then finally, option D was wrong because advising the patient to seek legal counsel before continuing treatment, this really shifts the burden to her without addressing her immediate mental health needs. While legal advice and services may be a beneficial long-term solution, it's really delaying care for her severe PTSD, and that's what makes this option less ethical as the primary response. All right, let's move on to question number 2. A PMHNP receives a request to release patient records for a legal case involving a 45-year-old male patient with a history of bipolar disorder. The patient currently is stable on lithium, declines to provide consent, citing privacy concerns, and has no active suicidal or homicidal ideation. The PMHNP must determine the legal basis for disclosing protected information, or PHI, under the Health Insurance Portability and Accountability Act, or HIPAA. Under which of the following conditions is it legally permissible to disclose PHI without patient consent? Our options are A, when a family member requests access due to concerns; B, when the patient is undergoing an involuntary psychiatric hold; C, when the information is subpoenaed by a court; or D, when requested by the patient's employer. All right, and our answer here is going to be C. When the information is subpoenaed by a court order, best identifies the condition under which it is legally permissible to disclose PHI without patient consent. So under HIPAA, this is HIPAA 45 CFR 164.512, PHI can be disclosed without patient consent in specific circumstances, including when required by a valid court order subpoena, provided the provider verifies its authenticity and limits disclosure to the minimum necessary information. So in this question, a 45-year-old male's refusal to consent, despite his stability on lithium and lack of imminent risk, does not override a court-issued subpoena related to the legal case. So the PMHNP must comply by releasing only relevant records, for example, treatment history pertinent to the case. Then we need to notify the patient, if possible, per institutional policies, and then document the disclosure, aligning with the PMHNP's legal and ethical duty to balance patient privacy with judicial requirements. So why was option A wrong? When a family member requests access due to concern is not a valid basis for disclosure without consent under HIPAA. Family members require patient authorization or a specific legal exception, for example, danger to self or others, which is absent in this case, so this makes this option incorrect. Option B, when the patient is undergoing an involuntary psychiatric hold, this allows disclosure for treatment or safety purposes, for example, under the 45 CFR 164.512J, but this patient is stable and not currently held. This condition applies only during active involuntary status, rendering it inapplicable in this case. And so finally, we have option D. When requested by the patient's employer, this lacks legal grounding under HIPAA for routine disclosures. Employers need patient consent or a specific legal mandate, for example, something like a workers' compensation in some cases, which is not indicated in this question, and that makes this option incorrect. Okay, and let's go ahead and move on to the next question, which reads, a PMHNP is evaluating a 55-year-old male patient with severe depression, scoring 24 on the PHQ-9, who requests electroconvulsive therapy, or ECT, as a treatment option after failing multiple antidepressant trials. The provider thoroughly explains the risks, for example, memory loss and confusion, the benefits, like rapid symptom relief, and the alternatives, like medication adjustment and psychotherapy. But the patient struggles to recall details of the discussion, appearing disoriented during the session. As a PMHNP, you must ensure ethical and legal standards are met before proceeding with this invasive treatment. What should the provider do next? Option A, proceed with the treatment since the patient initially gave consent. B, have the patient sign a consent form and move forward with the procedure. C, reassess the patient's decision-making capability before proceeding. Or D, proceed with the treatment only if a family member agrees to the procedure. And the correct answer here, hopefully you're able to get it pretty quickly. That one's going to be C, reassess the patient's decision-making capabilities. So we have to reassess that decision-making capability before proceeding in order to demonstrate that you understand as the provider what the priority is next. So informed consent for a procedure like something like ECT is going to require that the patient have decision-making capacity, which includes the ability to understand relevant information, appreciate the situation, and then understand the reasons behind the options and express a choice as per ethical standards. And these are all based on the American Nursing Association Code of Ethics, or the ANA's Code of Ethics, and also all of the legal requirements like informed consent laws across the nation. So this 55-year-old male's severe depression with that PHQ score of 24 and the inability to recall the risks, the benefits, and the alternatives despite initial consent, that's really going to suggest that we have some potential cognitive impairment or some type of disorientation, possibly due to his depressive state, or it could just be because of a co-occurring condition like delirium. So the PMHNP must reassess his capacity using a structured approach. All right, so consult with a colleague if needed and ensure that he comprehends the ECT process. Those are all really important steps in this whole process. If capacity is lacking, a legal guardian or a surrogate decision maker may need to be involved, but only after proper evaluation, and that's going to align with the PMHNP's role in upholding patient autonomy and safety. So why was option A incorrect? Well, proceeding with the treatment since the patient initially consented, that's really going to overlook his current ability or inability to recall details, and that's going to violate informed consent requirements. And this really risks performing ECT without valid consent, and that's making it an unethical and really it's a potentially a legal situation for you, and that's why this answer was incorrect. Option B, having the patient sign a consent form and moving forward assumes capacity without reassessment, which is invalid. If he cannot contain or retain or understand the information, this approach bypasses the need to verify that comprehension and then making it inappropriate for the patient in this case. And then option D, proceeding only if a family member agrees to shift to this treatment. This is going to shift that decision making to a surrogate without any confirming information. And we have to confirm that the patient has incapacity. So doing anything before that is just going to be premature. So family input may be sought after the capacity assessment if needed, but it cannot replace a patient's autonomy without legal justification, and that's why option D is incorrect. All right, moving on to our next ethical principle question. The question reads, and you know what, let's go ahead. I want to give you an example of how we do this in the actual session because we utilize our test-taking strategies that are taught in the course. I'm going to use a few here. There's a lot more that we actually learn about in the live sessions, during the conferences, the live conferences, and also the on-demand seminars that are available. So I'm going to read the question first, then I'm going to rephrase it in my own words, and I'm going to come up with what I think the answer is, and then I'm going to go through a true-false approach. So a PMHNP is managing a 29-year-old female patient diagnosed with borderline personality disorder, or BPD, who presents with repeated suicidal threats over the past week, including a recent statement about overdosing on her medications. She firmly refuses hospitalization, expressing distrust in treatment settings. But her mental status exam shows emotional instability, and we have a Zanarini rating scale for BPD score of 18. The PMHNP, after assessing her risk, believes hospitalization is necessary to ensure her safety. Which of the following best identifies the ethical principle that supports this decision? All right, I've read it, and now I'm going to go through, put it in my own words, and on the exam, I'm going to be highlighting keywords by using the Prometrics tools, right? So I have a 29-year-old with BPD, emotional instability. We have a really high BPD assessment score of 18. I have assessed that hospitalization is required, and what ethical principle does that support? So I'm thinking of things like, is this just for the patient? Is it showing their autonomy? Is it doing am I doing what's best for my patient? So I'm going to be looking for something like that. So now I'm going to go doing a true-false approach. Is A true or false? And then moving on. A, justice. Well, I thought it might be justice, and justice is just, it's fair for everyone, right? Maybe fits here, maybe doesn't. I'm going to keep it for now. B, beneficence. Now, I know that beneficence kind of goes in line with the other ethical principle of non-maleficence, right? Those can sometimes be confused. But in a sense, this is just doing what's best for my patient, right? And in my opinion, putting her in hospital without her desire because she could hurt herself is really doing the most good for her, right? And I'm preventing from doing harm like we would see with, non-maleficence. So I'm going to keep B for now. Autonomy, I'm talking about taking away her autonomy in this case. So I think C's got to go because it really doesn't make sense for a principle that supports my decision. And then fidelity, she's probably going to lose, right? This sense of fidelity in me if I force her to go into the hospital without her consent or without her desire. So I'm probably going to get rid of D as well. And so that leaves me with A and B as my 50%. And my best guess here moving forward is going to be B, and that is the correct answer. So beneficence, this best identifies the ethical principle that supports the decision of the PMHNP in this case. So beneficence, if you'll remember and recall, is a core ethical principle in healthcare. It obligates every provider to act in the patient's best interest, prioritizing their benefits and their safety, even when it really conflicts with the patient's preferences or their autonomy. So this 29-year-old female's repeated suicidal threats, including that plan to overdose, and her emotional instability with that score of 18, these really all indicate a significant risk despite her refusal for hospitalization. So the patient's belief that hospitalization is necessary reflects, the PMHNP, right? Where the patient doesn't necessarily see it, but you as the PMHNP, we believe that hospitalization is necessary. That is going to reflect doing the most good for the patient, which is the very definition of beneficence. It aims to prevent potential self-harm, right? A duty underscored by the ANA's Code of Ethics. But this must be balanced with legal standards. So things like imminent danger, justifying involuntary commitment, and then documenting with a thorough risk assessment. You have to document clearly here, potentially involving a second opinion or a family input if that is feasible or required. And that's going to align with your PMHNP role in managing high-risk BPD patients in an ethical manner. So why is option A wrong? Justice ensures fair treatment and resource allocation, relevant to policy but not directly applicable to overriding a patient's refusal for safety. It just really lacks the patient-centered focus needed in a case like this. Option C is wrong because autonomy upholds the patient's right to refuse treatment, right? So a key consideration in BPD where fear of abandonment drives such refusals. But it's going to be overridden by that safety, right? When safety is at stake, this principle supports her choice, not the PMHNP's decision, and that's what's rendering this one inappropriate. And then finally, D, fidelity involves loyalty and truthfulness, okay? So this is loyalty and truthfulness to the patient. So an example would be maintaining confidentiality. But it does not provide a basis for overriding her refusal. It supports trust building, not the decision of hospitalization. And that's why this particular answer is incorrect for this question. All right, moving on to our next question. We're going to talk about Stark law. So the question reads, a PMHNP is reviewing ethical and legal considerations in psychiatric practice to ensure compliance with healthcare regulations. The team is discussing scenarios that might involve violations of the Stark law. Which of the following situations best illustrates a violation of Stark law in psychiatric practice? Option A, the psychiatrist referring a patient to a therapist employed at the same hospital. B, a PMHNP receiving financial incentives for prescribing a particular brand of antipsychotic. C, a psychiatric provider discussing a patient's case with an interdisciplinary team. Or D, a PMHNP accepting an invitation to speak at a mental health conference. use your test-taking skills here, just like we practiced in the last one, and then take the other 30 or so that we learn in seminar, and we get our best answer of B. Okay, so B, a PMHNP receiving financial incentives for prescribing a particular brand of antipsychotic, that is going to best illustrate a type of violation within the Stark Law. So the Stark Law prohibits physicians, providers, nurse practitioners, insert whatever word you want to put there. If you're providing care, this applies to you. And this definitely includes PMHNPs in many states where they are recognized as a providing physician or a provider state, right? If you can put yourself in that position, this applies to you, okay? So this prohibits us from referring patients to entities like pharmacies or labs with which they have a financial relationship. So a PMHNP receiving payments or incentives from a pharmacy or a lab or a company that's pushing a medication, unless an exception exists, right? So in-office ancillary services, for example, this rule applies. And this is aiming to prevent self-referral that could inflate costs or compromise the care of the patient. So this PMHNP receiving financial incentives for prescribing a specific antipsychotic brand, this creates a financial relationship that could ultimately influence how they refer and how they prescribe. So that could potentially violate the Stark Law if the incentive is tied to a designated health service like outpatient prescriptions. And no exception is met. Now, there are specific exceptions to this law, but you better know what they are and how they apply. And it doesn't apply in this case. So the PMHNP must disclose such relationships. They have to cease the incentive arrangement that's been established in order to ensure prescribing aligns with clinical need, and then aligning the PMHNP's role, again, to uphold the legal and ethical standards that we all must live by. So option A is wrong. A psychiatrist referring to a patient to a therapist employed within the same hospital, this may fall under the in-office ancillary services. So you can see how that would be an exception to the rule. As long as the referral is within the same legal entity and meets regulatory criteria, like the same group practice. This does not inherently violate the law, and that's why it's incorrect. Option C, a psychiatric provider discussing a patient's case with an interdisciplinary team. This is standard practice. It should be a standard practice of care in your clinic in order to coordinate care, and it does not involve any financial relationship or self-referral. This is protected under HIPAA and treatment exceptions, and that's why it is compliant and therefore incorrect as a violation. And then finally, D, a PMHNP accepting an invitation to speak at a mental health conference. This may involve financial compensation. It may be there, but it does not constitute a referral to a financially related entity, okay, or body. So if disclosed and not tied to a specific patient referral, it falls outside of Stark Law scope, and that's why this is incorrect. As a matter of fact, we want to be doing that. In our sessions in the student portal and in our live conferences, we talk about the roles and responsibilities of a PMHNP, and one of those is absolutely going out and teaching and mentoring to the largest population possible. So we want to be a part of these conferences. All right, and that ends it for tonight. Those were our 5 practice questions that we did at our most recent Wednesday night live session. We go over the questions. We go through each one of these questions in depth using the test-taking strategies, and then students are allowed to ask whatever questions they need in order to really understand this information and make it concrete in their learning. So at this point in time, we would then turn it over to the students in the live session, where they're able to ask questions about their semester in their school, the review program if they're already taking it, materials that you found on your own in studies, any practice questions that they've completed but maybe didn't understand or think that the answer was totally wrong, but in fact it's right, and then we can discuss why. Really, it's an opportunity for you to ask anything that you want, and we give the time to the students so that way you feel like you're involved in a program that is just like a school environment, and you're not just stuck on your computer day after day trying to do all of this study by yourself. So we wanted to give that live time to you every Wednesday night at 7 p.m. Mountain Standard Time. We also end with a couple of quotes just for some inspiration, and so I wanted to end tonight with a couple. The first one is going to come from the Dalai Lama, and I love this quote. I think it is so appropriate. Just one small positive thought in your morning can change your whole day. Wake up. I'm going to pass this thing. I'm going to go on to become an amazing provider. I'm going to learn along the way. I'm going to mess up. But at the end of the day, I'm going to do my best. And that will change your whole day. And then finally, we have one last thought here. The elevator to success is out of order. Okay, just go ahead and put that out of order sign on every success elevator you're trying to find. You'll have to use the stairs one step at a time. That is such a great thought, right? We often want to just get into this magic box, push the highest level, and go all the way up to the top of the building and enter the penthouse, right? But that's just not how this is going to go. In order to get your certification completed and to accomplish these goals and these dreams that you've set, that success elevator is out of order. It doesn't exist. And you're going to have to open that door and just take the staircase. Take one step at a time as you go up. Take rests where you need to, but ultimately arriving at your goal. All right, and that is the end of our Wednesday nights live sessions with me, Dr. Rossi. Hopefully this was beneficial for you if you just wanted to listen to something on your way to work or laying down to go to bed. I know it can be hard to look at videos all the time and to read. So utilize these as best you can. I want it to be a tool if it's something that you want to use. If not, then move on to the next thing and don't worry about listening to me explain this stuff, and you'll be okay. But it is my absolute pleasure to be here with y'all day in and day out and being a part of your PMHNP certification journey. If you've been to my live sessions, you've heard me say this, and I 100% believe what I'm telling you right now. Nurse practitioners, we are the future of American healthcare. You cannot survive the American healthcare system without the strength and the backing of nurse practitioners. 10 years from now, it just will not be sustainable. So what does that mean? It means that we need to go out there and we need to put ourselves out there. We need to get the highest education we possibly can. We need to be the deal makers. We need to be the board members. We need to be the presidents of the hospitals. We need to be everywhere we can be, showing them that we can practice at the level of our education. And if we can't, then we are out there lobbying with our other nurse practitioners, other nurses, other lawmakers and educational providers, as well as doctors and PAs, all coming together to get us to the point where we have full practice in every state. And I will continue to rally for that and do what I can and do my part and speak up. And my hope is that you will too, because you have what it takes to change somebody's life for the better. You just need to go out there and make it happen. So go study, do what you got to do to get that certification completed. And when you're done, make sure you give me a call so we can celebrate together. Until next Wednesday, that's it for today's session. And go out and make the difference that needs to be made in order to help your populations get the best mental health care that they can possibly receive. Thank you for watching, for listening, for being a part of the program, and we'll see you next time. Bye-bye.